Dr. Harshal Sabani. He's a leader of preventive and social medicine at SSR Medical College right here in Mauritius. His work focuses on education, on preparing the next generation of medical professionals to integrate longevity science into their practice. In his presentation, Integrating Longevity Science into Medical Curricula, Dr. Sabani will share strategies for embedding geroscience education into medical training to ensure that longevity principles reach every clinic and hospital. Please join me in welcoming Dr. Sabani.
Good morning, everybody. I'm here to talk about integrating longevity science into medical curriculum. First of all, I'm a bit of an aberration here. My name is Dr. Harshal Sabani, but according to the organizers, that's not it. It's Harshal Sabani. And if you have to believe the website of the event today, my name is yet to be decided. So I'll have to give my mom and dad a call about what's the holdup. So that's one aberration. The second aberration that I noticed is I don't look like many people you heard here. They have washboard abdomens and, very lean. I think if you have to be a part of longevity, you have to, look the part of a longevity expert. I'm not that. I'm an educationalist. I'm a professor and head of community medicine. And of course, it's an excuse of not being fit, but I don't belong the part. So that's about me. I would start my talk with prefacing this with a problem that we have with longevity itself. And of course, my look at the whole problem would be from a very different perspective from what you have been listening to with all the experts here. This is a problem which we usually start our clinical postings with in medical school when they come to my department. So we usually give them a case like this. Rhetorical, I won't be taking answers from you. But this is a diabetic case who is a middle-aged man. He has some comorbidities, and I ask the students, what are you going to do to manage this case? I just tell them this. I don't give any further cues. I just tell them how are you going to manage the case. And I sort of let you marinate with this for a few seconds. And you'll come to realize that you immediately latch onto the clinical aspect of it. You tend to think about investigations. You tend to think about surgeries. You tend to think about how do I get to cure this patient. And that is an exact problem with education right now. Prevention is not the first thing that comes to my mind. In fact, an average medical student at this point of time, I have begun to come to see him like this. This is an average medical student in a medical school, and it is not his problem. It is the way medical education is delivered in medical schools. The blinders that you see on the horse, those are race horses. We want the medical student to focus on a department specialization. Are you pregnant? Welcome to OBG. Do you need a surgery? Welcome to surgery. If you do not have a pregnancy, OBG doesn't look at your cataract. If you do not have a brain tumor, a neurosurgeon is not interested in you. In fact, that reminds me of a famous quote from Dr. House where he says, you pick your specialist and you pick your disease. And that is what is happening right now in medical schools, that we teach them in silos and then students just look like this. That has to be first broken for prevention to happen. So we want those medical students who look more like these free horses who have a holistic view of what is happening around them and can appreciate the whole situation. They need to understand that disease is not one biochemical or a pathological finding, but an amalgamation of a lot of social factors. When I put this photo and I was driving to the venue, I realized that the medical student is still a horse, so we'll have to do something about that in the next session. This problem that I just described, I have begun to come to call it as a mummy mode, which I think most clinicians are, at least in my opinion. The patient tells me a problem and I tell him a solution. That is what we become. You call your mom right now and say, Mama, I'm thirsty, and the next thing she's going to say is, have water. I know that. That's what essentially curative medicine has become. So we have to move from that place to a more holistic perspective and look at the disease from a lot of other angles by which it is affected. If this is a problem of preventive medicine, imagine what are you proposing? Longevity medicine belongs to a domain in community medicine which we refer to as primordial prevention, the prevention of risk factors from emerging in the first place, which is even a larger, tall order. And I'm sure that this is going to be a huge, huge challenge to sell. Right now, longevity medicine, apart from the circle of experts that we have here, of course, if you talk about this to an average layman on the street, they might think of narcissistic tech bros who don't like the idea of dying. So I can throw any amount of money at you, just give me something which doesn't make me die. From that pedestal, we have to take longevity medicine to a place where it is deliverable to a common man. We have actionable insights, and it's low cost. My subject, especially community medicine, although it is not anywhere written in the textbook that it is by the poor, for the poor, it tends to be. It tends to be that way. So we want interventions which are low cost, high impact, and those are not easy. You might have heard about a lot of confusions during the presentations. Some researchers say that it is way ahead of the curve to talk about genetic markers because we do not have conclusive evidence. And the very next researcher shows you some genetic loci saying that these are the ones which we are targeting. And that kind of confusion is not amiable to be passed on to medical students. So we need a lot of clarity of thought. I'm thankful for the organizers and all the doctors who have presented here, especially Dr. Evelyn and Dr. Newman, and we are going to coordinate and collaborate with them to get the data from them to translate that kind of confusion into actionable, teachable modules. So why health and longevity matters right now? Well, all of you know that the world is going through a big, big transition. We have a problem. Initially, we were afraid of population explosion, right? We are going to consume all the planet's resources and we are going to run out of resources. That was the problem. And right now, there is a sudden chatter about a big tech bro, Elon Musk, and a lot of other demographers that we are not producing enough babies, as a matter of fact, and we're collapsing. That is a big, big problem. The problem that you do not see the population collapse happening right now is something called as a freight train phenomenon in demographics. What it means is that demographic momentum moves very slowly, but once it gathers momentum, it is very difficult to stop. Right now, the train is stopping. It is coming to a halt. There will be a time where the train will completely halt and actually go in reverse. And when that happens, when the reverse momentum catches, it will be more difficult to catch that train in the reverse. Surprisingly enough, I find in my own practice, in my own dealings, that we are not talking about it enough in the local context. Probably because Mauritius belongs in the African continent, as you know, and the rest of Africa is growing, but Mauritius doesn't behave like a typical African country. Although geographically it does belong to Africa, it doesn't behave like a typical African country, but Mauritius suffers from the same problems of low birth rate. So we are going to see this in the coming days, and that has to be dealt with. Now, traditional medicine focus on disease treatment. Prevention is not seen doctorish enough. So what we tried is we tried something called as early clinical exposure for medical students. Right in the first year, students go to the clinical wards now. That helps, but not really. And I tell you why. You look at the ratings that are observed year after year in medical schools by medical students for their clinical perceptors versus their preclinical and paraclinical perceptors, and you will see that there's a clear divide. Medical students, the general population, still see doctors who cut open a patient or give medicines as doctors and not the other people as doctors. And that is a big barrier to overcome. This is the data from Mauritius. Without going into the finer details, I'm just going to take you through the highlights. Just look at the total number of population in the next 20 years and in the next 40 years, and you will see that there is a systematic drop in the total number of people who will be living in Mauritius, the population of Mauritius, and the total number of children in Mauritius. At the same point of time, what is concerning is the significant rise in the old age population. This demographers call something as a dependency ratio. We cannot help it as of now. Apparently, telling people to have more kids doesn't work. It's not that simple. And with this, the burden that the society, the productive part of the society will have to support is going to be bigger. One of the ways to dealing with this is to make the old age people more productive. And that is why we are all here. We want to make the old age people more productive so that they keep on contributing to the society and we do not suffer from the burden of this demographic non-dividend. These are some of the statistics. I won't delve you with those. The core number that I would want to take your attention to on this slide is this. The fertility rates in Mauritius have dropped significantly over the last decades, and right now they're hitting 1.41. For those of you who are not familiar with this, the replacement fertility rate is said to be 2.1 for developed economies, and it is slightly higher for non-developed economies. But what I'm trying to say here is that even with the development of Mauritius, a fertility rate of this is way below replacement level. We are going to see a shortage of people in the decades to come. And older people have to transition from looking forward to their 60th birthday and starting the pension to actually working and contributing to the society so that they can keep on earning for themselves and giving back. So that's a very big red flag there. The other data that I would want to draw your attention to is in 2020, the number of people above 80 years of age, the ratio of male to female is about 1 to 2, which means that there are 2 females above 80 years of age per male. So if you are on Tinder and if you are above 80, you swipe left, right, center, you are matching. They don't understand the young men problem. Next is this that needs to happen. We need to shift from this method of healthcare delivery, which is problem-focused. We have a problem of aging population. If the transition of health span maximization and optimization of that health span doesn't happen, then we have a problem. How do we solve this? By this conference, of course, by geriatric science and healthy aging. And then we can have something of a proactive future of moving from reactively treating diseases, waiting for them to happen, to actually treating age as a modifiable risk factor. Now that also, for a doctor like me, treating age as a modifiable risk factor is a rug pull. You don't think of age as a modifiable risk factor. It is fairly and squarely placed in the non-modifiable risk factors as of now. But that needs to change. So we need to move from anticipatory to preventive medicine training. We need to start teaching about biomarkers of aging, cellular senescence mechanisms, what are the drugs that are available, and we need to have more importance on personalized preventive plans towards healthy aging practices. What is the expected impact of this? Well, the first educational impact is that we want to inculcate a systems thinking in the medical students. We want them to have an interdisciplinary perspective. That notoriously is very difficult. As of now, what we are doing at my medical school and medical schools around the Indian Ocean Rim region is that we are trying to implement something called as competency-based medical education. Now, this has been there for a very long time in the Americas, but it's relatively new in this part. So we have to merge and learn with other disciplines. So a nursing cadre cannot be working separate from a doctor's cadre and a physiotherapist cadre and so on and so forth. Inside a medical school, the Department of Anatomy has to talk with the Department of Surgery. The Department of Biochemistry has to collaborate with the Department of Pathology and so on and so forth. So that those kinds of integrations and alignments need to be done. Again, the problem that I see as a medical educationalist there is that we talk of it, but we risk that we might have more alignment and less integration happening at the end of the day. And that needs to be taken care of. I won't spend my time telling you guys what geroscience is. I'll be spending more time on telling my problem with what geroscience is and how do we deliver. Where we deliver is in formal medical curriculum, and we have, for the very first time, as I said, with Dr. Evelyn and Dr. Newman, very good resources and very good resource persons to be sharing. So we look forward to collaborate with them, to take those materials, to localize them for Mauritian context, and to start their deliveries in the days to come. We also plan to have a Mauritian chapter of the LHM in Mauritius in the coming days, and probably become a regional hub of longevity education to medical students, not just in Mauritius, but around the African region. So right now, as of now, the reason I stand here is because community medicine, my department, teaches most of longevity-related topics, but it's nowhere near the discussions that we have had. One of the problems that I have been discussing with some of you is that all of this looks very messy. It is not clear, and that's something which we, as I said, need help with. We need clear, actionable insights which are low cost so that they can be passed on to the population. So we need learnings from all of you as to what is really working and what is not working so that that can be passed on to the students and to the general population. An example here in Mauritius, a beautiful example, is the WHO ICOPE strategies. That document itself says that we need to include longevity medicine into undergraduate curriculum. The specific place where it says is this: strategic objective 4, priority 4, specifically objective 4.3, where it says to include modules of longevity care into medical curricula. And we are going there, not there yet, we are going there. So the fundamental underpinning resource for this is the UN declaration of the Decade of Healthy Aging from 2021, as well as Mauritius' ambition to become a longevity optimized nation. I do not know if you know this, that Mauritius also has a retirement visa for seniors who plan to retire on the island. So that is also there. So Mauritius also envisions to become that. So these are some of the examples, the ICOPE strategy in Mauritius being implemented. These are the 4 core modules. The modules are too many. They can be clubbed into these 4 categories. First is geriatric assessment. The second is geriatric management for prevention. The third is digital devices. And the fourth is community-based interventions. All the modules in the whole document can be clubbed into one of these 4 neat groups. Now, what are the current gaps in the training of the future doctors as of now? Well, the first gap is that the postgraduate specialization is lacking. We do not have a dedicated postgraduate system which rewards preventive medicine, especially longevity medicine. There is an interdisciplinary training gap, which I alluded to earlier. There is reactive disease treatment. We are still waiting for the disease to happen. There is a cursory geriatric coverage, not anywhere as much as we expect. And there is curricular polarization towards subject specialties and independent silos. The system gaps to this is not recognizing community medicine as a specialty branch, not having postgraduate dedicated diplomas and career pathways for longevity specialists, and the lack of faculty expertise. That hopefully will be changing in the coming years. And this conference, congratulations to the organizers, is a big, big step towards changing that. Now, preventive versus curative healthcare, this is something which we keep on sort of talking about. There's a huge gap in the perception, fund allocation, and the remunerations between preventive medicine and curative medicine. An average medical student thinks himself as Dr. Strange. You know, he drives a big supercar and he lunges into the operation theater, he makes dead people alive, and then he wears his fancy watch, has a shower, and off he goes to a party. That's not real life. Preventive medicine, definitely not. As you can see, the funding disparity for curative and preventive medicine is huge. They are not comparable. We have had some aberrations with countries like Netherlands, but that was only because of COVID, that they ramped up the prevention and the testing. But this is not by any means a rule. This is an aberration. What this funding gap does is basically it does not let any funds be for screening of diseases to be caught early. It doesn't leave any funds for educational programs for prevention of disease. And this is also reflected in research. You can get an immense funding for drug development, for surgical interventions, but for preventive medicine, the funding is not always there. Then you have cultural factors which hinder the development of longevity medicine in curriculums, and you have reimbursement structure, which I told you. A surgeon does a surgery for 1 hour, and he's reimbursed quite handsomely for it, especially in Mauritius. But you do a preventive health counseling, and that remuneration is nowhere comparable. And that sort of disincentivizes even doctors who want to do that to actually spend time on it. Why the Mauritius medical curriculum? Well, first of all, Mauritius is one of the leaders in the African region. It has got a very stable government. The lessons that are applied here, if they are successful, can be extrapolated to other countries. You have an emerging medical tourism industry. Mauritius wants to position itself as a medical tourist hub. And all this longevity medicine can be a very niche, high-yield pull for that longevity seeking industry. It's very well connected. Most of Mauritians at least speak 2 languages. Many of them can speak 3 or 4 languages, so they can communicate with a wide variety of people. This conference itself is a testament to the fact that we can pull specialists from all over the globe, and they're willing to come here in the first place. We can disseminate those findings. We can leverage that position of Mauritius. We already have AMLC here. fair disclosure, I do not represent them and I have no conflict of interest, but you have organizations which can translate and have events of this scale. There's a very well-developed higher education sector. As we speak, we have 4 medical colleges on a small island like Mauritius, and we have a unique advantage which a lot of African countries do not have. Very recently, a very interesting development that has happened on the Mauritian landscape is the development of a clinical trials unit. We can have early participation with the academia, the industry, and the government, the Ministry of Health for the clinical trials unit. And some of the longevity trials that we were talking about, those can be held here so that Mauritius can actually be really ahead of the curve rather than waiting for the foreign agencies and foreign findings to be extrapolated to us. The necessary requirement for this, the framework, the Clinical Trials Act and the Clinical Regulatory Research Framework is already in place. So I think there's a lot of scope for foreign pharmaceutical, preventive industry, academia, and the ministry to collaborate and work at the CTU. So what are the solutions? We have talked about a lot of problems. What can be done? What are the low-hanging fruits that we can pluck from here? First of all is that we can launch with the help of specialists like Dr. Evelyn, Dr. Newman. We can have a longevity module which covers the essence and the essentials of longevity medicine into undergraduate curriculum. This is not very controversial. This is relatively easy. The next is that we, as medical educators, can develop interstable professional activities so that this is not just theory. This is checked. This is validated. We can have mini CEX on this. We can have OSCEs on this. We can have a lot of didactic teaching supported by clinical experience by the EPAs. So they can conduct, manage, initiate, and interpret longevity-related interventions in the medical schools. It is important that we just don't stop at teaching. In medical education, one of the sayings that I like is assessment is the tail that wags the dog. And if you come to think about it, that is very funny and very true. Assessment is the tail that wags the dog. If you do not test it, students get a message that this is not important and they will never study it. So it is imperative that these EPAs are tested by any means that I mentioned earlier, but they are tested. What this also tells them is that prevention and longevity medicine is not just for the books. It is something that you have to do in your day-to-day life, and it is a part of a doctor's job. We can have faculty development, something which we are having right now and something which we plan to do in the future also. We can have interdisciplinary collaborations. This is something which is a lower hanging fruit because this will happen very shortly with the integration of CBME curriculum in medical schools around the island. Students can be included in things where they do stuff. They can be posted in the clinical trials unit. They can be posted in geriatric wards, take histories. They can be told to counsel for longevity-related activities. And that's something which we can place the students in those places. We can evaluate how these things are happening. In a medical school, we can take student feedback. We can see how the theory is doing. We can see how the practical is doing. And in the ministerial scale or the programmatic scale, we can see what are the hospital readmission rates, what are the investigation of longevity measurements, and so on and so forth. So these are some of the early indicators that we can roll out to check the progress of this. We can have dedicated CME and PG pathways. This is not ideal, but this is what we can do right now. Why do I say that this is not ideal? Students in Indonesia, by the time they hit 2030, all of them would have had some exposure to longevity medicine built right in their course, which is mandated. We do not have any such mandate. This is all voluntary. Now that is replaced by a CME or a PG. But like I said, PGs are better, CMEs are stopgap mechanisms to train doctors like all of us who might not have had this as a core module during their UG days. And then, of course, when we do all of these things, we have a complementary set of objectives to achieve. First is to combat ageism. When you say an old person, you automatically, as a doctor, you think, no, what is left in his life to do? The first case, if you recall, the diabetic case that I had showed you about the ulcer, I asked my students at the end of it, how many of you actually thought of asking this gentleman about erectile dysfunction? And this doesn't occur. This doesn't occur to us that this is something which you should ask about. You automatically expect this is an old man. The best thing he can do is go to bed, sleep. But he wants to sleep with somebody, and that's not something which he's going to shout on top of his voice. And that's an astute doctor's job to combat ageism and see that, okay, this is something which is an unmet need, and did I pay attention to it, or I just did not think about it because of his age. And that is combating ageism. At the same point of time, we have to combat therapeutic nihilism. Nothing can be done. More often, we do polypharmacy, right? There are too many drugs. Old people are taking so many drugs that it's a breakfast for them, right? And then, of course, side effects of this will be digital health literacy and self-directed learning. So a vision for the future is to have a generation of doctors who think proactively, work collaboratively with artificial intelligence and emerging technologies, understand aging as a modifiable research, as a modifiable process, and contribute to a more healthy and prosperous society. And for that, we need to integrate longevity medicine in medical schools as soon as possible, to build a longevity center of excellence in Mauritius, to partner globally and empower the next generation of clinicians. And for that, we need money. Sorry, the mic is leaking truth. For that, we need to collaborate with all of you, and that is what I am here for. I'm going to be bugging and networking with you guys to seek your guidance to translate all of this into actionable insights for us. I thank you for your time. This is my parting message. These are some of my references, and I look forward to having a chat with you later. Thank you.
The mic is leaking truth.
It does that sometimes.
A couple of questions came in. We face significant burdens from diabetes and cardiovascular disease, as everyone's aware. How can medical schools train clinicians to tackle these through a longevity lens, which is what you've started to touch on a bit?
Yeah, exactly. So what is happening right now is that we do not have, as faculty members ourselves or as doctors, we do not have clear markers of early detection of these diseases. And I'm sure that in the research circles, they are there, but we need to get them from those so that those markers and those senescing measuring agents can be applied in a medical school so that these students pick them up even before the risk factors happen. So for primordial prevention, we have exercises. You go to the Mauritius exercise centers here, and they do a bunch of stuff there. But we need some cellular markers also to tell the general health of the population. As of now, we do not have that. When we collaborate, when we learn from these experts, we will have more data and more information to teach the medical students to do that. As of now, we teach them counseling, we teach them risk factors, and we teach them primordial prevention, which is there in the classical domain.
One last question, and you talked about ageism, but there's also sometimes a gender bias in many things. And so one of the questions is, are there any studies aimed at helping women delay the age of menopause? And maybe just speak about just focusing on women's health as women are not men, and so are there changes or differences that you see maybe in curriculum coming up?
Okay, so I think this very conference had a special session on women's longevity. And that's very pertinent and that's very thoughtful because as you can see, as you age, women tend to outlive men. The only exception to my mind which comes to this rule is the country of Nepal, where men tend to outlive women. But apart from that, all over the globe, women tend to live more, and that is an issue. Helping women delay the age of menopause, I don't know why would they want to do that in the first place. If I was a woman, I would not want it to be delayed, but that's just me. So I don't know why that has to be there in the first place, because I hope that by 45 or 50, your family is already complete, and you're not looking for any more children. In fact, most females that I know look forward to having this, of course, without the side effects. But I don't know. I'm not the best person to answer that, to have an intervention.
Well, I think that does say that, and maybe in the future we can have a kind of a more focus on women's health. I mean, there are some studies that are showing that women might live longer, but they might live sicker longer because of some of the health issues that come up post-menopause. But I think that's for another day and another session, and thank you so much for a wonderful presentation. Thank you.
Thank you.